Yes. Episode 35 with Dr. Mark Tyndall talking about COVID-19 and the homeless population, IV drug use, dispensing, safe supply. Let's go.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved.
Ladies and gentlemen, welcome back. We're on episode 35. This is unbelievable. Before jumping into it, I want to give a shout out to our many super fans out there that have done a great job at purchasing merchandise, spreading the word on social media, interacting with our crew. So a special shout out to Eileen White, Michelle Berthium, Sarah Marsall, what's up? Rebecca Roy, Danielle Kuzar, and Dan. Just a special shout out to you guys because we love hearing from you guys. We love the fact that you guys are spreading the word. So thank you. I got one more shout out. Kim Sutton, host of the Positive Productivity Podcast. Yes, she is helping me design the new website. It's going to also help set up systems to better serve you guys and the community. To learn more actually about Kim and her services, check the link attached to the show notes, Solving Healthcare /Kim Sutton, and she'll change the game. She's changing the boogie. All right, guys. On our latest episode with Dr. Mark Tyndall, we talk about how COVID has affected the homeless population. He's works in inner city in Vancouver, so he's front lines. He's seeing the impact that's having directly. We dive into the tension COVID's created in that environment. We talk about how COVID affects supply of drugs and potentially can be more impactful than anticipated. We talk about the value of safe injection sites. We talk about how his My Safe project, which is so innovative, and you're going to read about this in the news about how a vending machine is dispensing drugs. But when we dive into the logistics and the reasoning behind it and how it provides a safer environment for not only the patient but also for the community, I think this will be eye-opening for a lot of people, like literally using biometric technology for his patients to be able to get a safe supply on a daily basis. I think it's just ingenious. So yeah, we dive into all that. So I hope you guys enjoy the show. A little bit about Mark. Man, this guy is a warrior. He's a TED speaker. He's an infectious disease doctor. He got his master's in clin-epi from Harvard, as I think they like to say it. He's been the executive medical director of BC Center of Disease Control. He's a professor of UBC School of Population and Public Health. He has got some street cred, and literally, because he's front lines. He's right in the midst of it. So without further ado, people, Dr. Mark Tyndall. Dr. Mark Tyndall, welcome to the show.
Thanks for asking me.
Absolutely. We talked about a few weeks ago, it was pre-COVID, and I was ultra excited to talk to you about, the safe supply, quote unquote, vending machine for drugs topic. But you have an extremely unique experience in terms of seeing what COVID-19 is doing to the marginalized population. I'm wondering if we could speak to what you're seeing at ground level.
Sure. Yeah. When we did talk about doing this show pre-COVID, as you say, I would never have thought we'd be in this position. I don't think any public health person would have imagined that we'd be in a kind of total clamp down. And it's really has impacted the work that I do and impacted the population that I work with more than the rest of us, basically.
Mm-hmm.
I I've kept a fairly low profile. I've also done a lot of my work from home. I do pop down there. I spent yesterday afternoon in the downtown east side around the machine. And yeah, it's heartbreaking, really. They can't really follow any of the directives. For many people, there's no real home to stay clamped down in. People still have drugs that they rely on to get, and that means they're still out there hustling. The sidewalks were full. It's leading up to welfare day, so there's a lot of angst on the street anyways, because many people have run out of money for the month, and the stress is kind of a powder keg. It's quite interesting that there's been maybe 3 or 4 reported cases down there, but it hasn't exploded as far as illness goes, and there's been very little testing. So it's still too early to know how much is circulating in that community, but it's not as though I'm walking down the street and everybody's coughing and short of breath.
Mm-hmm.
In some ways, kind of, looks fairly normal.
Mm-hmm.
But the one thing often gets bypassed is, of all the economic slowdown that we're seeing, it also affects illegal supplies. So there's a real shortage of drugs right now, or pending shortages. People are hoarding them. Prices are going up, just like for any commodity. Violence is going up. Just in a 3-block walk to the office yesterday, I saw 2 fights, and
Wow.
It's just really, disturbing just to see it. So it has had a major impact on the population, the living down there, but it could be way worse in a few weeks from now.
Yeah, it's interesting to hear your perspective, because I would have guessed, knowing that, sorry, I'm trying. I don't know. I don't want to keep calling them marginalized. I don't know what the term. Like, how do I refer
Yeah,
to?
it's a good question. People who are using drugs, but
Okay, yeah, like the people that are using drugs, the people that you're seeing, they're in close proximity. We know that there's COVID-19 out there, and it's interesting to hear that it's not clearly passing through them. Like, you're not seeing a lot more illness, at least yet. I don't know if that would be intuitive to most people. Like, is that what you were expecting at this stage?
Well, everybody's gearing up. I mean, a lot of the harm reduction programming and the community services have all cut back in response to this. The supervised injection site that I work with used to have 12 tables. Now there's 6. They're supervising outside now. The oxygen usage has been extremely capped and reduced for fear of spreading virus. So there's been quite a lot of preemptive work done down there, ready for something to happen, but the timing is still unclear. And it's not totally beyond the realm of possibility that it won't hit it big time. But everything that we know about transmission and the factors that lead to, quite large outbreaks are all in place in this community. So,
Exactly. Yeah. And that's why, maybe it is early. Maybe it's just part of their protoplasm, because we do know that, like, there's a lot of asymptomatic carriers and or low symptom burden. And, I'd imagine, the people you're seeing, there's a variety of ages, but including young patients that aren't necessarily hypertensive, diabetic, obese, kind of the factors that we're seeing associated with.
Although clearly there's a lot of, morbidity in that population. So, everybody smokes cigarettes.
Yeah.
There's just a lot of lung disease already in that population. I would say that's the number one morbidity in that is respiratory, a lot of bad cardiac and problems, diabetes. So, it's not a healthy population for the most part. So I do think there'd be a lot of poor outcomes for people who get exposed. In some ways, and this is not just the downtown east side. I'm quite familiar with, smaller problems or smaller communities across Canada. A lot in BC, and I worked in Ottawa for 4 years in Byward Market area. I mean, it's the idea that there is some insulation to that population. So the person who just returned from Florida isn't likely to walk through the Byward Market, or possibly there's some insulation to that population, but it's not totally insular. So inevitably there will be some virus introduced into the community.
Mm-hmm. Well, I mean, it's good to hear too that the measures are being made to try and reduce transmission. You've mentioned about the oxygen approach and the amount of people within an assessment that are being assessed at once. Like, I think that's important to mention. And sometimes it's all these little things that could actually make a difference.
Yeah, although the direct impact of these things is bad. So people, we've been promoting supervised injection sites. So all of a sudden the capacity is cut in half. We've, promoting
I see.
people coming together for food programs and trying to connect with social services, and all of a sudden they're closed. So it's maybe it's it's good that something's being done directly to COVID, but the unintended consequences of this are all bad. So people don't have access to the services. So
like we had Dr. Paul Offit on a couple of weeks back talking about exactly the unintended consequences. Like, we talk a lot about the economic side, but there's a psychological aspect too. And it's interesting hearing what you're seeing just walking to work. Like, almost like, is that a preview of things to come? Like, not only where you're working, but also throughout society. Because my wife, you might hear some background noise. She just came from Costco, and the amount of time she's telling me about the tension, even just going through the aisles, is unbelievable. And I even sense it walking outside with the kids. Like, there is that level of tension, and I wonder what you're seeing is just a precursor of things to come.
Oh yeah, I've been in the community long enough and know a lot of the faces. There certainly is built-in resilience there, and that people have faced. They face serious adversity every day. So it's, in some ways, it's just another thing. But yeah, no, it's, and it's a lot to do with housing and drugs. So that's always continues to be the big driver of people's issues. And that's just now multiplied several fold. And really the concern that people have over getting their drugs is really major. And the people that are, sending these drugs in the country over the border have the same kind of problems as everything coming over the borders. And it just means that people will make do with even worse drugs and mix all kinds of bad things in the street powders and things. So it will trickle down to having even a more dangerous drug supply. Already the overdose numbers are starting to creep up in that community, even in the last couple of weeks. And so
you're seeing that already, like more overdoses?
Yeah. I mean, it's just starting, but it was all, it continued to be bad in that community, but so many people had already died. I mean, a lot of the most vulnerable people are already gone, but the overdoses certainly were continuing. But the drug, as the drugs deteriorate, people will overdose more.
Yeah. And the other thing too, Mark, we were texting with a lawyer colleague of ours, and she was saying how in Ontario anyway, they're trying to almost like decant the prisons, like, because they're worried about a lot of people being in close proximity and worried about contracting COVID and the implications that has. But as I'm hearing you talk about this, now you're having more people that may be addicted to drugs that are criminals that are now out in the community with a shorter supply, with a more dangerous supply. Like, this is adding up to yuckiness, for lack of a better word.
Well, I think it's unethical to keep people in situations in jails and most people in pretrial that haven't even been charged yet in very, dangerous situations. But it's unethical just to say, okay, we're not going to bother with it now because it could be dangerous for you in jail. Just, head back out on the streets. I mean, we owe it to people to give them some options. We can't just give you you're on your way. But that's what we've been doing forever anyway. So we tend to, this people in pretrial and jails are often discharged with no plan. That's been a huge problem with the overdoses. So we take people who the first thing they do when they leave jail is search for drugs. They've been sort of detoxed, as it were, and they go down on their first injection. So we've always had a real problem with setting people up for disaster when they leave jail. And now with COVID, we need to have a plan. You just can't say that, we don't want to keep you here anymore. Just go find your way. As you say, that's just a recipe for disaster in the communities.
Yeah. Maybe this is a bit of digression and we could keep this or not, I don't know, but what level of planning are we really doing? Like, I know it's clear, like, I'm a believer that social isolation is working, but, the conversations we're talking about, the unintended consequences, I feel personally that they don't happen enough. Like, aside from marginalized patient populations, you do hear there's more domestic abuse. Kids, like Child Protective Services, for example, they're getting less calls because the kids don't have an avenue to be recognized. Like, they often will talk to their teacher, or the teacher will recognize kids that are being abused. This is not something we're talking about, and it's clear to me that this is a big issue. I wonder, just because, you got that infectious disease background, like, and maybe it's not fair because you're not in, but like, you do work in public health, but like, do you feel like we are thinking about these steps?
Well, not enough. I think that the media has really positioned public health as those people who are counting the numbers, how many new infections they've uncovered and how many people are in the ICU and how many deaths. And then on the other side, and we're seeing it more in the US than in Canada, this is all about business. This is all, people are losing their jobs. We're destroying our communities. We're destroying our businesses. And so public health has sort of been positioned as those of us who are fighting to keep the numbers down. Where public health is, that may be should be the perspective of a hospital worker or a doctor working in an ICU. But public health, by definition, needs to take a much broader look at this rather than just counting heads and counting numbers and counting the flattening of the curve. This is our responsibility in public health, is to take a more global perspective. And what are all these unintended consequences happening? And it's more than just numbers. And so I think that, through no fault of some of our public health leaders who are, doing, what they have to do, but the media has really pitted like those stingy health people who want to keep us all in our homes versus, the more, freedom loving people who want to get back to work. And so, but public health really needs to take much more nuanced approach to this, that it's not just numbers, it's really all these unintended consequences that are happening to people. And we need to start measuring those somehow. And the example you used, we need to do it. Well, how much depression, how much more substance abuse is being caused because people are staying at home now. I think it's huge. A lot of people's secret life of addiction is in their homes. And so now we're asking people to stay in their homes. So what do we expect? The numbers are important, obviously, but public health is more than just those numbers. And we need to start thinking of the long-term damage this is doing to our society. And I don't have any, great insight into how this should all happen. I think that the idea when the population level of infection is very, very low, like it is across most of Canada and certainly in British Columbia, approaching this as though everybody has it and so we need to stay away is, you could question if that, do we have to be a little more nuanced about this? Testing would obviously help, but doing outbreak investigations as we normally do in public health. But I think we'll come to a point where if we know the population exposure is quite low at the community level, just continuing to approach this, with quarantine is not going to be sustainable.
I really like the point you made, Mark, about public health is just not like it's more
all encompassing. And I think really, like you don't see models, as we said, we don't see models for the unintended consequences. I mean, I haven't seen one, and I need to search harder. But to me, the reason why also it's important to have the conversation is because maybe we could do something about it. You know what I mean? Like maybe we could invest in, in the abused house. Maybe we could invest in more visits to the home or virtual visits to the home. Maybe, when it comes to any of the other measures, we could just put some thought into it. And so, yeah, I think that's a really good point you make though, about like what it means to be involved in public health. Cause yeah, we're not having that conversation.
No, and I don't see any end in, like the homes for the aged are a good example where instead of, I think the lockdowns had to happen for sure,
Yeah.
but now the investment should be in video screens, and we have to sort of adapt to the situation. We can't just leave your relatives just alone in a room by themselves till they die. I mean, it's just not practical, and we can do something better than that. So we need to start thinking how we're going to adapt to this new model and make it reduce the unintended consequences. And when we hear our public health officials, and again, I think, I have no criticism as far as what they've been told to do and how they're conducting it, but all the media, all the questions are, how many cases today? How many people in the ICU? How many dead? Oh, we're flattening the curve. Isn't that great? Like, so the focus is entirely on on the COVID outcomes, and rarely any questions are asked about, what else is happening in society from a health perspective. You can measure how many unemployed people there are and things like that. But I think there's a lot of things we could be measuring and following better. And that by measuring them, then it could bring it up into the, put it on the agenda. And then we could start seriously thinking about, how we can address these and try to come up with some mediation.
Yeah, no, I absolutely. I'm definitely on the same page about that. I want to talk to you about Safe Supply, the work that you've done to try and provide safe drugs to IV drug users, to do your part to reduce the amount of overdoses we're seeing and to get people off these medications. Where to start? Maybe a bit about like what landed you into this role, like to do this work?
Well, if you want to be bored with the whole history, but I'm an infectious disease doctor by training. I grew up in the HIV era. So when I graduated from medical school in 1985, and so I was in medical school when the first article hit about a gay disease in New York City and San Francisco in 1982. So I've sort of grown up in the HIV world my whole career. And when I was training at McMaster, I got involved in hemophiliac clinics and men's clinics that were essentially gay men with early cases of HIV. And then I was quite interested in international health. And so I spent 4 years in Kenya studying HIV prevention when there was really no, the early 90s when there was absolutely no treatment. The transmission was wildfire. And the clinics I worked in basically were lineups of dying people that I could offer them nothing other than a test and say that, here's some condoms, try not to pass it on to others. And so those were like pretty crazy times. And although I moved back to Canada in the mid 90s, I still maintained research projects and collaborations in Kenya for about a decade of work doing that. And then I took a job at the BC Center for Excellence in 1999 and in HIV. And that was really my first introduction to HIV among drug using populations. And at that time, the downtown east side was also famous for HIV prevalence rates of 30% and things just out of control. And when I arrived at the HIV world of drug use, that intersection for, I guess over 20 years. So, and that led me to, HIV prevention. I was a treater, so I was really advocating for people when treatment became, more available that people using drugs should not be eliminated from that, because when the drugs first came on, they were hard to take and needed quite a bit of support and supervision. And people who were using drugs were not thought to be good candidates for this. So I was pushing that, we have to, it's just unethical to let people die when we have treatment, and we have to adapt our system to make it possible for people to take multiple drugs multiple times a day. So I worked on that. And then that just led into a kind of a whole world of harm reduction. So I was involved in evaluating Insight when it opened in 2003, supervised injection site. And I've kind of been at the harm reduction part of things for the rest of the time. And, ironically, when I took a job as leading the BC Centre for Disease Control in 2014, I guess. And my goal there was to try to get out of the drug use HIV world a little bit and expand my horizons. The BC CDC was doing all kinds of other things, from, shellfish infections to respiratory diseases to, it had a very broad mandate in public health. We had vaccines and other sexually transmitted infections. And so I was trying to, just my own personal growth, try to diversify and learn a bit more about that. And then soon after I took that job, the overdoses started rising and fentanyl came. So then I've been back at it, basically. And I always thought that the best thing we could do for people is offer them a safe supply of drugs. So right from the beginning, promoting supervised injection sites, it became clear to me that having people arrive at a supervised injection site with the pocket of illegal drugs, that 80% of the harms that were happening had already happened that day. If you were out on the street early in the morning, hustling for drugs and doing whatever it takes to get those drugs, by the time you arrived at Insight and flopped down on a chair to use them, a lot of your problems were already behind you until you left and had to find more. Right from the beginning, I thought that, we should just be giving people drugs here. It's just a crazy idea that we put people through this system that drives them into all kinds of problems with the law, and they're homeless. And that if we could solve that by just giving them the drugs and helping to regulate and modulate them. So I've been, and I gave, 100 tours through Insight. And for the non-educated, one of the questions always was, well, don't you give drugs here? And, oh, no, we want people to go out into the alleys and, steal from cars and steal bikes and sell sex. And we that's what we expect them to do. And then when they get here, we'll give them a smile and they can sit down with a clean needle. And it made no, when I heard myself describing what we asked people to do, it made no sense. Basically, the message is don't use drugs. And this is this is a little bit of thing we could do. Instead of injecting in the rain, you can come in here and less likely to share needles. And if you overdose, we can intervene. But it's a pretty small offering when you think of the whole scale of people's lives. So, and then it became crystal clear that when people were buying poison on the street now, at least if you had a nice supply of Afghani heroin in your needle, people could, get by and they weren't likely to overdose. And, and people can use heroin for decades and, they get by. But then when fentanyl came and all this other stuff that people were injecting, it made no sense to set up these overdose sites and just intervene in overdoses all day when they're bringing in this stuff. And we know we have alternatives. So I published something in CMAJ, I guess 2016, say what we need is a regulated drug supply. And the idea of a safe supply, it's called now, was pretty foreign to most people. That was not really part of the harm reduction lexicon, a safe supply. If you talk to a lot of early activists and things, everybody was kind of talking about it. It's stupid me getting these drugs from the street, but that was never really part of anybody's plan. But so over the last 3-4 years, I think we've really come a long way in thinking that this could actually be workable. And so, and with fentanyl, I really thought people needed safer supply. So the one thing that we build on in Vancouver is a clinic called Crosstown, which gives injectable heroin and hydromorphone, and have done that for a decade. It's built on two large clinical trials, Naomi and Salome, which showed that people do better when you give them drug. But I saw that it's just too limited and it's too expensive, and it's not for everybody. So it takes a very specific person that will go 3 times a day and use drugs under supervision and hang around there. So from a public health response, we need to go beyond highly medicalized model. And what would be a reasonable substitute for many opioid users who are using heroin and fentanyl would be hydromorphone pills or dillies, and that they were quite popular on the street. So after a lot of focus groups and talk, I've had a lot of experience with people using drugs, and so I tend to know quite a bit about how people use drugs now, that hydromorphone would be a good substitute for people. So I wrote a grant to Health Canada to give out hydromorphone pills over 2 years ago now. That was approved, but I just ran into 2 years of roadblocks with regulators, but most specifically addiction doctors and primary care doctors who basically were going in the opposite direction, that these drugs were bad, that we should not be giving them out, that we've caused a lot of damage by prescribing these drugs in the first place. And so there was very few prescribers who were willing to give these drugs out as a safe supply. So that was a huge obstacle and continues to be a problem. And then, maybe I can pause there. I've talked.
Basically, you're saying everything I want you to say. So I mean, maybe before we talk about like what you're doing now, it's interesting. Like maybe it's worth diving into, like, especially some of the non-medical folk listening. It's like, really, what are the consequences of not having a safe supply, not having a safe injection site? Like, what happens?
Well, I mean, I think the downtown east side is a great, kind of microcosm of, forward thinking, a lot of experience down there. But our model is still highly medicalized and really based on methadone and more recently Suboxone, which people need to understand are abstinence-based treatments. They're saying that the drugs you're using now are bad for you, that if you use these drugs under my rules, which are quite stringent, you can take these substitution drugs that you can avoid drug sickness and cravings, and you can get through your day without using drugs. But they do not get you high, and we do not want you to be high for, I think, puritanical reasons, not really medical reasons. And to me, hydromorphone or morphine or real opiates do exactly what methadone and Suboxone do. They prevent withdrawal symptoms and they prevent craving, but you also get high. And that's a huge leap for a lot of treating physicians and community in general. Why are we wasting taxpayers' money on some medications that actually people feel good when they take them? And we're totally not comfortable with that. I kind of understand, but to me, giving somebody the drugs they want to make them feel better for themselves is not that different than giving them methadone and Suboxone. We know for a fact that most people on methadone and Suboxone continue to use other drugs. They chip away at other drugs. There's quite a few people who have died of fentanyl poisoning who are on the methadone program. And fentanyl especially is a very potent opiate, and you can override the blockage that methadone supplies for you. Suboxone's a little harder. But again, when we promote these substitution therapies that are highly studied, and they would be considered, like, we have a lot of evidence for how effective these are. None of this evidence is randomized trials. So when people decide to get on a program, they're ready to try a substitution therapy, and they're often succeed. And so a lot of physicians have a whole list of people who are doing very well on their methadone treatment. And that's great. I think it's great. But if they look out the window, there's so many people who aren't on anybody's program. And if you don't do my program, then I'm not really responsible for you. I'll take you in from a clinical perspective and try and help you. But if you're a person who either didn't come in the door in the first place or have not done well on my methadone program, then there's not much more I can offer you. And so I'm trying to push people to think in a more public health point of view, not just a clinical point of view. There's 5,000 people in BC who've died of overdoses in the last 4 years. So clearly what we're offering them is not good enough. Like we need to get on this, and just offering more of the same, really pushing more doctors to prescribe substitution therapy definitely has a role, but we're still going to leave a huge gap out there of people who aren't ready to do that or just not willing to do that. They use drugs to numb the pain that they're feeling, and we're not, until they deal with that, then the drugs are what they want, and people, use these drugs for self-medication. And the people that I've, in my, long experience with this, I've seen a lot of people reduce or stop using drugs entirely. And it's not because they got into some really cool treatment program. It's because something clicked in their lives. They reconnected with a kid. They got a house. They got, they just had an epiphany one day that this is terrible for me. I need to get on with things. And so all of the supports we can offer people can help nudge them in that direction. But usually it's a personal decision that people make at some point that they're just not going to do this anymore. And it's often because something clicked. And for many people that I deal with, nothing clicks. Everything goes in the wrong direction. Their lives are just filled with trauma, and it just happens over and over. And we put them in positions where there's just no way they're ever going to catch a break. They're living in poverty. They rely on criminal activity. They're in and out of jail. They've been, isolated from their families and their loved ones. And so it's just, it's heartbreaking every day when I, talk to people who, are looking for some break, and every day somebody died or they got another illness or they lost their housing. Or it's like, it's unimaginable, just the repeat trauma that people are put through. And it's really led by our drug policies, which say what you're doing is illegal and you better get on with things. And so many people are left behind because they just don't get on with things, or they can't.
Yeah, I mean, I think we had a show with Dr. Tyndall about, his clinic, inner city clinic. And, when you really sit down and listen to some of these stories of what people are going through, it's hard not to have your, melt your heart. You know what I mean? It's like, these are real people going through real issues. And, sometimes it takes a little bit of a outside the box thinking to be able to give them optimal care. Right.
Yeah. And our expectations, if you in term, Jeff, I know quite well. And I actually listened to the show with him. So it was excellent.
Thanks.
If you're a treating physician or healthcare worker and you say you've figured this out and you look at these, look at my practice, then you're targeting the wrong people. I mean, the 15 people that I have on the MySafe machine, they've all done remarkably better. Are they is their lives back together after 3 months? No. I talked to 3 of them yesterday. I mean, they all say they're doing better, but the one person I spent most time with yesterday, his sister died 3 days ago. He's using more drugs the last 2 days. That's the way people cope with things. He's almost all apologetic. I was doing really well on the program, but I started using some fentanyl yesterday. And so these are expected. People, I can't, change 20 years of trauma for people in a month. It's a long healing process that people need. And I think, my main role is just to allow people some openings so that they can work through this trajectory. And my expectation isn't that you'll stop using all drugs. I think that's just not realistic for most people. It's a process. They got there. It took them a long time to get there. It's going to take them a long time to get out. And it's not hopeless. And, my feeling about recovery and how people put pressure on, the people at least that I'm familiar with over my 20 years of experience, there's nobody that had like, we're clear sailing, tried drugs one weekend, hit rock bottom, and now we're going to recover. These are most people's life trajectory isn't like that. That people were struggling along with all kinds of things happening to them, all kinds of trauma. Drugs became part of their solution, and they've continued to do that. But everything in the background has continued to be messy and traumatic, and it's very hard to recover from that. And so we have to get away from this idea that we're going to miraculously, do a 180 and, your life's going to be totally different now because I've done something for you. Your life could be improved and heading in a different direction because of things I can do for you, but it's not instantaneous. And I think Jeff would have the same feeling that this is a long process for people. There's no quick fixes here. And the least we can do is offer them medications that they can use without killing themselves. And so that's kind of at the bottom line. People aren't going to recover or ever going to get another trajectory if they're dead. And that's kind of my bottom line. And I've just seen too many people die. There's just no second chance when you inject that lethal fentanyl dose.
100%. I wonder, Mark, maybe we could even walk people through the program. Like we mentioned, there's 15 patients, but like what all does it entail?
So it's been a long, long road to do. So I really feel there's two barriers. One is the whole discussion about safe supply. So does the medical community and governments and the public feel that we should be offering people pharmaceutical supply of the drugs they want? And that's a huge hurdle, and that's an ongoing discussion. And I think in BC, we just have some new guidelines that kind of give physicians, some assurance that it's okay to do this, but it's not going to happen overnight. We can't flip a switch. And the other thing is using technology in public health. So I felt that the only way to scale this and operationalize this was using technology. People, as much as we think connection's really important and we need to, really be around for people, most people using drugs want to do it quietly and have some autonomy over what they're doing. And by getting their pills out of a machine and being able to take them with them was, I thought, a huge step, like kind of safe supply 2.0. So I maybe bit off too much at the beginning, thinking that people would accept technology, but I persisted and got a machine in BC in 2019 and in December. So I've had it going for about 4 months now. I wanted just to prove that and to test for myself. It had never been done before, so I had questions myself. So I just handpicked 5 people to join the program just as a feasibility. Does the biometrics work? Do the people use their hydromorphone? Is there problems with diversion? Is there issues with people being targeted because they're on the program? How does the software and reporting work? So there was, things I needed to work out. It's up to 15, mainly because of compassion, because there's just so many people around who want a piece of it, and a lot of people I knew. And so we're up to 15. But since myself, I'm doing most of the prescribing and running the program, there's one colleague who's doing a few of the prescriptions now. And most of the support for the machine is volunteerism. So I don't have any real money to do this. The company Dispensation is providing the machine, and they're like close partners in this because they're working through, modifications of the machine and the software also. So we've got those 15 people. The machine can hold 48. So, and basically it's like a big ATM. It's an 800-pound machine that's bolted to the floor. It's got a big video and a contact screen that people can interface with. And the biometrics, we scan people's internal vein pattern in their hand, and they just stick it up to the machine, and it welcomes them to the machine. So it's no PIN numbers or cards or anything like that. And every pill coming out of that machine is tracked in real time. So I know that this person got 4 dilly 8s at 7:30 this morning kind of thing. And that's in real time. I have a dashboard. I can follow people. If somebody doesn't come for a couple of days, I can send out, we need to find what happened to so-and-so. That hasn't happened very much. There's been no drop-offs, no dropouts, which is pretty remarkable for any program. So everybody wants to do it and continues to do it. People were coming 4 times a day initially because I was, forced to be quite conservative with it. But after COVID hit about a month ago, everybody now is getting once a day pickup. So I don't want to, and so they don't have to come multiple times to the machine. Mm-hmm. They can be in and out of the room in like 15 seconds. So it's just put your hand up, bang, bang, the machine dispenses it. And then if you come back too early, it'll tell you have, you can come back in 16 hours or something like that. So it's very regulated how much drugs come out of the machine. And I can follow up with people anytime. They can send messages on the screen and they can message me. So it's be very interactive that way. So the technology, and it avoids all the, right now, say, how would you get people safe supply? Well, they'd have to line up at a pharmacy or they'd have to have them delivered to their place. And in COVID, that just makes no sense. We don't really want people to do that kind of stuff. So the technology, I think, is really slick from an operational point of view. And so we're getting, there's 5 more machines now that are being made.
Oh, really?
And we have a bunch of community partners that we're setting up right now. And I'm hoping to get these 5 machines delivered within the next 3 or 4 weeks. So we can scale it up. But I'm really, I still don't have any funding for this. We're talking seriously to Health Canada and other provinces because this was a great idea in the beginning, I think, it was going to be the only way to scale up safe supply. But now with COVID, it just makes all the more sense to use automation and technology to try and get this stuff out.
Wow. So, Mark, like I'm 4 years old. You want a safe supply. You are one of 15 patients. You go to this machine. It will scan your hand and based on your vein pattern, be able to identify who it is. Get that supply once a day. You get to, in real time, know whether they've taken the supply or not. And they avoid going into a pharmacy or wherever treatment center, getting their methadone, whatever it might be. They avoid having to go in and out of facilities, keeping a safe distance from, other people. Well, I got to give it to you. That's thinking outside the box and embracing some technology. It's pretty innovative. And sounds like scalable. Like that machine does not sound very cheap, but maybe it's cheaper than a pharmacy. I'd have to think about that, my econ side, but
yeah. So it's it's a company that I deal with. The kind of face value of the machine is about $25,000.
Okay.
The way we're trying to roll it out is it's $2,500 a month. But that includes the enrollment station, the IT support, the setup, the reporting. So half of that almost is kind of the support that's needed for the IT. And most places, because we're modifying there's things that we're modifying as we go, putting more telemedicine capabilities, because it could just be functioning as a telemedicine thing, basically.
Right.
So for rural communities and things. So it's probably not worth buying one anyway. So basically it's about $2,500 a month, which is just that's less than a healthcare worker to monitor a program or give things out. And it still offers
less than an overdose.
Yeah. No, it's
you know what I mean? Like an ICU admission. I mean, that first day of ICU admission range anywhere from $3,500 to $7,000. Well, even up to $10,000, depending on how sick you are.
Yeah.
So if you're thinking about prevention and potentially cost savings, what's been the feedback though for people in the community or some of the maybe conservative?
Well, the community. I mean, again, I live in a bit of a bubble in the downtown east side. It's been hard to get kind of funders and the ministry to embrace this, but that's not totally unexpected with most innovations in harm reduction. That governments want to be showing proof that it works. And I'm always faced with, well, what proof do you have? I said, well, I have 15 people that are doing well on it after 4 months, and I can give you some statistics, but it's just 15 people. So it's really a pilot stage now, and we need to just roll it out more people and get some more solid data. But I have no, there's no even slight concerns that I have that this could not be a scalable solution for the regulations around it. So I have letters of support, strong letters of support from the business associations that are often anti-harm reduction in different cities. So they see this as why not give people a safe supply of drugs, and why not use automation? The Vancouver Police Department is very pro this. They look at this as a crime prevention strategy. So why are we asking people to go scrounge around for illegal drugs that causes so much chaos in the community? Why not do it? So the Vancouver police and this municipality, the city, Kennedy Stewart, the mayor of Vancouver, has been very proactive and very vocal about this. And then the community itself is very supportive. So the drug user groups and things. So it's really, I think it's at a cusp where it could take off, but I haven't, there's no resources that have been allocated at this point. I should say also that as far as the regulatory part goes, we haven't, there was quite a lot of concerns from the College of Pharmacies and College of Physicians, but how I'm describing this as just a lockbox for people's drugs. So I'm still a doctor, I'm still writing prescriptions, the pharmacy is still recording them, they're still being dispensed, and now the people in the program have just signed a form that their medications can be dispensed through a safe, secure, regulated source. So it's basically a lockbox. And if people have very unsecure housing, how could we possibly give people like a bottle of pills, and where are they going to keep them? How are they going to keep them safe? They're living in a tent, they walking around the streets. I mean, it's totally impractical. So this basically just gives them a safe lockbox to keep their own prescription. So I haven't challenged any of the current pharmacy regulations to get this going.
Yeah. No, it's pretty, like I said, innovative, thinking outside the box, and from what you're describing, there's a lot of upside. Can you think, Mark, of an individual or a story that's really where this innovation has really helped that person?
Oh yeah, we've done follow-ups. I've been kind of low profile the last few weeks. I was one of those crazy people who went away for March break, so I had to stay in my house. But no, I had a conversation or a FaceTime with a person just yesterday who now wants to go to get a week's supply. And he's been he hasn't missed a dose. He was getting 4 times a day, and then I was giving him daily with COVID. And he's at the point where he's an older guy. His birthday is exactly the same as mine. So he's an older guy and wants to stay in his place. He has a stable place to live. He's been in it for a while, and he wants to get a week's supply. And so I said, yeah, you should pick it up at the pharmacy now. There's no reason to come to the machine to get a week's supply. It's not hard for you to drop by a pharmacy once a week. So this guy went from quite unstable, buying fentanyl on the street, doing all kinds of stuff to get his drugs, to now being able to collect enough money, to save enough money because he's getting the drugs for free, to get stable housing, and now he can get a week's supply. And so I just get these effusive emails or text messages from him. This is thank you so much. This has changed. Wow. And his life is totally changed than it was 4 months ago. It just miraculously changed. So, not everybody's going to be like that. He's probably one of the few people that I think is ready for weekly, because other people are still not in stable housing or still, I think the one thing with liberalizing the safe supply is that we do have to recognize that people do have a compulsion and an addiction, and we're not really doing people a favor by giving them a week or two of these pills and hoping for the best, because they'll come back for sure in 2 or 3 days saying, look, doctor, I don't have them anymore. Now I'm buying fentanyl. So it just doesn't do them any good. And it doesn't do, the system any good to kind of give people more than they can actually handle. So I think most people should probably stick with daily pickups, and they can monitor and adjust their drugs over the day. But going beyond that for a lot of people it's problematic for them, and pills will go missing. And I've dealt with this over my whole career. I mean, you give people prescriptions and medications, they don't take them and they've lost them, they sold them.
Exactly.
So I think, this allows a very individualized approach. So we can program that machine in real time that you have to come twice a day, or you can come once a day, or and it's all timed out. So we can, in real time, regulate it. If people are in a bad stretch, we can tighten things up. If they're on a good stretch, we can loosen things up. So it's very, very flexible way to prescribe in real time. So yeah, he's one guy that I think has done remarkably well. There's another guy I spent time with yesterday who, ironically, this guy, I saw him first when he was 19 years old, which is 20 years ago, when he had very end-stage HIV and living on the street. A First Nations guy, such a sweet person, but had so much trauma in his life. And I just connected with him and got him on antiretroviral medications. And if through my whole career, so you want to be bored with the story, but I gave a sort of public presentation at the Science World in Vancouver around the overdose crisis. And sorry.
No, take your time.
Oh, I've told this story more than once, and so I didn't think it would really hit me. But so, anyways, he was in the audience, and
oh wow,
he stood up, and I recognized him, and he sorry. So I was amazed that he was still alive, because I had moved to Ottawa, and then I'd be back to another job. So I literally hadn't seen him for a decade. So he was doing okay when I was looking after him regularly, but I didn't have, any ability to, keep in touch with him when I was moved away. We weren't like friends or anything, but I knew him very well. And so I said to the audience, I've seen, thousands of patients over my career. And as physicians, you hope you make a difference, but we really don't know. We're like a cog in the wheel, right, of people's lives, and people come and people go, and we do our best. And but if there is one person that my whole career that I had an impact on, and it was him, like.
And he was there.
He was there. Yeah, I think I saved his life.
Wow. Yeah, no, absolutely.
Okay, I'm glad this is editable. So
yeah, exactly. But Mark, isn't this exactly what we do this for? Isn't this exactly what gets us up in the morning? Isn't this why we hustle? Like, it's in a lot of ways, what we do often is thankless. And when you could, I honestly, I could not imagine that moment. Like, seeing him in the audience, the one, right?
Yeah.
Like, oh my God.
So he was one of the first person I got on the machine. So he is in the program, and I saw him yesterday. So he came in when I was around the machine. He was a guy who said he was having a really tough time because his sister just died this week, and he we talked quite a bit, but he's still hanging in there. The one fascinating thing about him also with the program is that he he isn't injecting them. So the pills are, my assumption everybody's grinding and injecting them. But as we were sitting there, he prepared his hydromorphone pills that he just got out of the machine and snorted them up. And he said, yeah, he's found this is really useful for him. And he's not using needles, and that the route of administration, that he's decided that he doesn't want to use needles anymore. But anyways, I think the real, heartwarming part of the story is that, the guy had end-stage HIV 20 years ago when treatment wasn't that effective. It's very hard to get people on these complicated regimes. We managed to do it. His HIV is under good control, but he still uses drugs. Like he's still, that's the way. He's had a lot of trauma in his life. It continues to happen. He's doing okay. But how I couldn't live with myself knowing that there's so many people out there like that who are, doing their best, but have to rely now on a very dangerous drug supply. And he will continue to use opiates for the foreseeable future. And if his only option is to buy fentanyl powder, he is going to die. And it seems crazy after all he's been through and all the medical system he's been through to get him to the stage he's at, that we would not offer him a lifeline, that we just say, things are bad out there. We know the fentanyl is going to kill a lot of people, but we're not going to do anything. Almost like if coronavirus came and we just decide, it's going to kill a lot of people, but we're not going to be able to do anything. It would be like having a vaccine for coronavirus and telling people they can't have it. Like it's, we have something that can totally prevent you from getting this, but it's illegal, and we don't, it'd be better off if you just stayed in your house, because vaccines, we really don't want to give them to you. So it's almost the same thing with the safe supply. Like we know what people are going to do, and we're saying, you should really stop. That would be the
and it's an evidence-based practice, and it's like when I think of the story of that young man, like where honestly wouldn't be alive unless you intervened. You're a part of his puzzle of reducing his harm, keeping him out of our intensive care unit, keeping him, having complications from other, like from injecting, for example, and he's here. And and he's, I don't know, I don't want to say he's necessarily thriving because I don't know that, but he's here.
He's here.
Yeah. Wow.
And I think that's a huge message too. So I think that our expectations have to be like that's his life. I'm not necessarily a libertarian kind of person, but who am I to continue to punish this guy, or in a society, and continue to punish this guy because he's wired to drugs? Like I don't know, that's the kind of most unreasonable response we could ever come up with. Like this, you have an issue with your addiction, and the only thing I'm going to do is punish you for that over and over and over again until you decide you're going to stop. And that's the opposite of what we should be doing. Like this is, there's an issue here. It's very problematic for you to be doing this. How can we make it safer? How can we make your life better?
Yeah.
Not how can we make it worse with some kind of this ridiculous idea that if we make things so bad for people, they will stop. And that is just not our experience. That is like 100% not our experience. So
it's about, honestly, Mark, it's more about making it like not making about our ideals, but making about what's going to work for them. Because I think this is a theme I think a lot of problems stem from is I'm putting my judgment on how things should be, as opposed to like, what's a solution that's going to work? Like, how am I going to be able to execute knowing what our goals are and knowing who the person in front of me is?
Yeah.
Like we don't ask that question enough, not only in medicine and life in general, but like, that's what it really, when it comes down to it, when you want to just like dissect it, that's really what it comes down to.
Yeah. And and in addiction, as all through medicine, we become very protocol driven. This is the evidence. These are the protocols. Check off all these boxes, and then we've done great. here's my bill. Like, and so we've left very little flexibility in the system because these are the rules that you have to follow. And then sometimes, ironically, we get new evidence that that's the dumbest rule we could have ever had, and we switch it all up. So, it's really, we tend to be just blindfolded and not really look at the situation we're dealing with. And it couldn't be more true with addiction, which is really so many social factors involved in this, and not really, that we could go on another whole thing about medicalization of addiction. You serve some purposes to say this is a medical problem and should be treated like any other disease, but it's not really. It's a social problem, and we don't have, a lot of the solutions are not medical at all. They're much more social, and so we do damage to people and the system when we try. The medicalization of addiction is also have some unintended consequences.
Amen, brother. Mark, this has been so much fun, and honestly, we're going to be doing this again because I'm now recalling a few points that I thought about in our conversation beforehand, and it kind of reminded me when we start talking about evidence-based practices and people thinking like trying to like abiding too hard by protocols and so forth. But regardless, thank you so much for doing the show. I learned a lot. I know my audience is going to be learning a lot here. I love the outside the box thinking, and I think we should be embracing that more in medicine. And once again, stay safe, and thanks so much for doing this.
Okay, no, my pleasure. I didn't get this chance to say that you're the Michael Franti of healthcare podcast. So I like your intro music and things. So it's
yeah, that's what we also got to talk to some beats.
Yeah,
I'm a music enthusiast, and Ida, our mutual friend, I forgot, she told us about she told me about some of the concerts you guys have been to, but we're going to talk about this. Yeah, I went to med school with Ida.
Oh, I didn't know that, actually.
Oh, I didn't tell you that? Oh, my goodness. Okay. Well, we're going to shut this down. Yeah. Thanks, everybody, for listening, and we're going to talk about what we just talked about.
Okay.
Thanks so much. Thanks, everybody, for listening. By the way, that interview took place April 21st, 2020, just to put things into context. If you want to subscribe, follow us. We're all over the place. Instagram, Twitter, YouTube at Quadcast. Leave comments at quadcast99@gmail.com. We got a mega episode coming June 1st, 7 p.m. Eastern, talking about lessons from COVID, featuring Dr. Brian Goldman and Dr. Jane Philpott, former Minister of Health, and the one and only Andre Bacard. So please jump on that train. Stay tuned for more information. Otherwise, everyone out there, stay healthy, stay tuned, and stay safe.